Good afternoon, everybody. I am Professor Rasika Herath from Perinatal Society of Sri Lanka. Perinatal Society has decided to take up various academic activities to help doctors, professionals who are taking part in care of COVID pregnant women and the neonates. So, in this attempt, we have identified few themes to discuss. This is the second of the webinar that we are organizing with regard to COVID infections and pregnancy. This is conducted with the help of experts from other specialties, and we have invited two consultant physicians and a pediatrician and a consultant community physician to help up with this endeavor. The webinar is on clinical update on COVID infections in pregnancy and newborn care. In this regard, we have invited Professor Shaluka Jayamanna to give his lecture. He is a professor in medicine from University of Kelaniya. He will be speaking to you about overview of COVID infections in pregnancy. It's over to you, Dr. Jayamanna.
Good evening. I must thank the Perinatal Society for inviting me. COVID-19, I will briefly describe an overview of the infection. So, we will discuss the virus, the pathophysiology and the clinical presentation, and the pharmacology and the evidence we have. So, this is the virus which we all know, and as you know, the important components of the virus is the spikes and this nucleocapsid protein and the RNA, because as you know it is a RNA virus. So, spike on the outside mediates receptor binding. Membrane proteins assist viral assembly, and a nucleocapsid protein regulation of viral RNA synthesis may interact with M protein during virus binding. So, that is the novel coronavirus. The old coronaviruses were mostly associated with upper respiratory tract infections, but the novel coronaviruses are associated with the lower respiratory tract like SARS, MERS and SARS-CoV-2, which is the COVID-19. So, there is a zoonotic mutation that is being proposed, and the SARS-CoV-2 has been associated with pangolin, as I have shown here. So, this mutation would have occurred in November, December 2019, and that has changed the world a lot. So, we see a virus with no herd immunity. Incubation period of 2 to 14 days. There have been prolonged incubation periods of 27 days reported. Symptom onset median day 5 and 6. Doubling time is 6 to 7 days. Viral shedding occurs early in the disease, and prolonged shedding also noted. However, this is what happens when the virus enters the body. It will attach to this receptor called ACE2, S2, and this virus then. So, novel coronavirus has attached to S2 receptors, which are seen in alveolar cells, epithelia, buccal epithelia, upper intestinal epithelia, myocardial cells, kidney proximal tubule cells, bladder and urothelial cells. So, after attachment, this viral replication occurs, as we all know, and the expression of ACE2 is substantially increased in diabetic and hypertensive patients, and especially who are on ACE inhibitors. So, they are at an increased risk of severe disease. So, here what happens in this process, the virus enters, as we see, rapid virus replication occurs in the alveolar cells. And there is an interferon response, which will lead to pro-inflammatory cytokines and chemokines, and accumulation of monocytes and neutrophils, and release of this so-called cytokine storm, which includes interleukin 10, 1, 2, 18, MCP, IFN, and interleukin 6, which is the most closely associated, and which will lead to multi-organ dysfunction, acute respiratory distress syndrome, renal failure, and viral myocarditis. So, if I describe this, now the initial binding of the SARS coronavirus is the secretory cells of the nasal mucosa to the ACE2 receptors. Then viral replication and local progression occurs, and it will conduct down to the airways, to the respiratory tract, the lower airways. Invasion of the type 2 pulmonary alveolus epithelial cells. So, this takes some time, some few days, and then we see this cytokine storm with release of these cytokines. And in the meantime, there is viral replication and release of viral particles in the host cells, and there is chemoattraction of neutrophils, CD8 cells, B cells, and sequestration and the inflammatory response, which will be described. Here, the continuing viral replication occurs on the other side, and diffuse alveolar damage with resulting in acute respiratory distress syndrome. So this is a more graphic representation of what happens. And one of the important things is these cytokines cause injury to the endothelial cells, and as a result of that injury, what happens is the activation of platelets and activation of coagulation and clot formation, which we call as microthrombi formation at the level of these vessels. And that will lead, and also there is increased permeability due to the damage of the endothelium, and the plasma tend to leak out and cause something similar to pulmonary edema, which is called non-cardiogenic pulmonary edema. So this is a more complicated graph, but what it says is here the cytokine storm, which is being described, and this cytokine storm ultimately leading to the cardiac failure and the respiratory failure. So these are the cytokines that are more closely associated with COVID-19, interferon gamma, TNF alpha, interleukin, and especially interleukin 6 has been very closely associated, and interleukin 18, which comes from different cells that are responsible for the release of these cytokines. So, stage 1 is the mildly symptomatic viral phase, which usually occurs in the upper respiratory tract. Then moderate pulmonary involvement, viral phase is still predominant at this stage, which is stage 2. And then you go to the stage 2B, which is entirely an inflammatory response, and then go to stage 3. So, the severe pulmonary systemic hyperinflammation occurs. So, this sequence is important. No, this is where we can use the immune modulators, corticosteroids. So, timing matters. So, timing matters. There is a therapeutic window of COVID-19 drugs. So, for example, in the viral phase, the remdesivir and interferons will be more effective, whereas in the inflammatory phase, intravenous immunoglobulins, dexamethasone will be more effective. So, how do we know what point this so-called cytokine storm occurs? The COVID-19 patients, when they get, they usually get a lymphopenia less than 1,000 lymphocytes per millimeter, and then you get the rise of the D dimer over 1,000, LDH over 3,000, 300, and ferritin over 500. So, if you have at least 2 of these parameters, then there is a high chance of this cytokine surge. If you have only one serum parameter, then you have to check the CRP. CRP is more than 10, then again there is a high chance of CS-CoV positive. And this was trialed in this trial, published already. So, this is some guide to identify the cytokine storm. So, it will lead to a hypercoagulable state because of these cytokines. There will be elevation of factor 8, elevation of fibrinogen, circulating prothrombitic microparticles and neutrophil extractor traps, and the hyperviscosity, which will lead to so-called this hypercoagulable stage, which will lead to pulmonary embolism and DVT as described. So, clinical presentation, it's a varying between individuals. Most patients will have mild infection, which is about 80%. Severe disease is seen in about 20%. And of course, the critical disease is seen only about 5%. So, this is what we are worried at the moment, what we are dealing mainly. So, initial signs and symptoms: fever, fatigue, dry cough, anorexia, myalgia, dyspnea, expectoration, pharyngitis, diarrhea, nausea, dizziness, headache, vomiting, and abdominal pain. So, those are the common symptoms which we see at the initial stages. So, what is the cause of the disease? Week 1, you will have fever, most of 98%, intermittent or persistent, fatigue, malaise, and a dry cough only. And dyspnea, only very small percentage will get dyspnea. Less common symptoms are myalgia, headache, sore throat, nausea, vomiting, nasal congestion, and hemoptysis. The second week is the 6 to 9 days, which we expect the so-called cytokine storm. 15 to 20% develop severe dyspnea due to viral pneumonia and hospitalization and supportive care. Week 2 to 3 of the hospitalization, 1/3 ultimately need ICU care, with up to half ending intubation. These figures may change with Sri Lanka, but this is the world figures that we know. Can rapidly decline with mild hypoxia to frank ARDS, cytokine storm and multi-organ failure, late stage sudden cardiomyopathy. At the latter part of these COVID patients, we see they go into cardiac failure with a severe myocarditis. Now, this takes a fairly significant number of days. So, we can measure the level of severity. Mild is respiratory rate of 12 to 20, heart rate of less than 100, 94. They are just mild cases. And moderate is when the respiratory rate is about 20 to 30, and heart rate of more than 100, and oxygen saturation 90 to 94. And then severe is respiratory rate more than 30, heart rate of 120, and oxygen saturation less than 90 at presentation. So, there are some comorbidities associated with COVID-19 severe infection: age, hypertension, diabetes, coronary artery disease, and hepatitis B, cardiovascular disease, COPD, and malignancies. So, this is initially in initial literature, if you go through the about COVID-19, it was said that the pregnancy, the performance with the infection is fairly similar to the other women. But now we know with this publication from JAMA Pediatrics, which shows that there are a significant number of complications that are more compared with the normal population of women with COVID-19. So, we know about RT-PCR. I am not going to elaborate on this, but I want to highlight here is a single negative RT-PCR does not exclude COVID-19. If RT-PCR is negative but suspicion remains, you have to repeat the test. So, if still I think for general audience I must mention that WBC is usually normal, but there is a lymphopenia, 80% mild thrombocytopenia. There is a low procalcitonin, which differentiates it from bacterial infections. CRP and D dimers are elevated proportionately to severity. Increased ALT and AST, mild elevation of creatinine, generally normal troponin. The ferritin is classically high, LDH is high, and now we know that interleukin 6 levels, which we measure as a prognostic factor in some situations. Chest X-ray sensitivity is 59%, bilateral patchy reticular infiltrates, and HRCT, the sensitivity is high. So, in clinical suspicion, you can go for HRCT. Initially, the ejection fraction is normal, and at latter stage, when they develop the myocarditis, ejection fraction drops to about 10. So, factors associated with poor prognosis is age over 65 years and male gender, the comorbidities as I have mentioned, and hematologically lymphocyte count, decreased lymphocyte count and increased neutrophil count ratio, neutrophil to lymphocyte ratio is a bad prognostic factor. LDH more than 245, procalcitonin more than 0.05, increased AST, bilirubin, and creatinine. Inflammatory factors increase CRP, interleukin 6, and ferritin, and D dimers, increase D dimers, and endotheliopathy, like these are of course we do not generally measure, but these we usually measure, and which will give an idea of bad prognosis. I think this will be discussed about the triage, and so, but I want to highlight one thing that which we increasingly see in pregnant patients is that their oxygen saturation is sometimes comes to normal with oxygen, but the respiratory rate remains high, and that is generally bad prognostic factor, as we see. So when always, I think most of the wards go by oxygen saturation. The oxygen saturation may be 95, 96, but if their respiratory rate is high, I think that is a bad prognostic factor, and we should take more action. The treatment, of course, as you know, 80% of people have mild to moderate symptoms, and basic outpatient management with cough and cold medications. Avoid steroids. There have been no significant benefit of giving steroids to these mild symptomatic patients. Probably avoid ACE inhibitors and NSAIDs. Need to protect family members, check, and at least 2 weeks isolation is recommended. So, moderate risk, which can go into critical symptoms, may need inpatient management, oxygen, and watch for rapid progression. And severely critical symptoms, we have to use either high flow oxygen BiPAP, as it will be discussed here. And then moderate patients, there is exactly the place of antibiotics and antifungals have not been identified. Of course, procalcitonin will be a guide, because that is the marker that will remain normal if there is no bacterial infection, because all the other inflammatory markers are high in COVID except procalcitonin. The steroid could increase viral level shedding from the lung and reduce pathological hyperimmune response. At last, not high doses and recommended pulse steroids, but we'll come down to recommendations later. It is important to watch for cardiomyopathy, especially viral myocarditis, which can lead to cardiogenic shock. So these are the areas. This is actually a bit complicated, but you can see in this graph we show where the areas where pharmacological treatment is targeted. It is at this level. This is the level where interleukin 6 is released, and commonly prescribed tocilizumab is an interleukin 6 inhibitor. Then corticosteroids probably suppress the level here. So corticosteroids, especially dexamethasone, is widely used now. Then at the viral level, there is nucleoside analogs, remdesivir, that is being trialed and accepted by the WHO. Earlier, lopinavir and rinovir studied, but now not recommended. There is suggestion of chloroquine acting at this level of viral replication, but now we know that to get this effect, we need a very high dose of chloroquine, and which can be harmful to body, and therefore now chloroquine is not recommended. And there are other sites that have been targeted in the trials going on at the moment. Very well proven is, somewhat proven, or the WHO accepted, is remdesivir and tocilizumab, which are at these 2 levels. So tocilizumab level of interleukin 6 correlates with COVID-19, as you know, severity, which suggests that immune dysregulation and ARDS may be influenced by interleukin 6. Since interleukin 6 promotes endothelial dysfunction and development of vascular permeability, the cytokine may play a role in vascular dysfunction associated with this disease. And tocilizumab is a monoclonal antibody against interleukin 6 receptor alpha that is used to treat certain inflammatory diseases. So data suggests possible benefit for tocilizumab in time until hospital discharge or readiness for discharge. Basically, the tocilizumab did not change the mortality in the trials, but what it changed is the ICU stay and the severity in the ICU stay. Then in this year, days of tocilizumab not being available, there people recommend bevacizumab, but it's not really in the WHO guideline. It is an anti-VEGF, or vascular endothelial growth factor, monoclonal antibody. Hypoxia induces VEGF expression through activation of polyhydrolase, and VEGF is a potent vascular permeability factor that induces the vascular leakage. Now, as I mentioned earlier, the pathology is as alveolar damage and vascular leakage, which lead to non-cardiogenic pulmonary edema. So basically, this is antagonizes that, but the trial results are still not very well accepted. Remdesivir, out of the many antivirals tried, remdesivir had shown some benefit, although the significant benefit is not reported. Remdesivir was originally developed for the treatment of Ebola. It's a nucleoside analog, competes with the neutral nucleoside during the replication, and the efficacy of remdesivir is found ambiguous against severely affected patients that remdesivir shorten the time until recovery, but need not have a significant effect on the 14-day mortality. So that's the trial published. Chloroquine, as I mentioned, it probably decreases acidity, and in addition to chloroquine, and hydroxychloroquine can also impair terminal glycosylation of ACE receptors, thus inhibiting the viral penetration into the cells. However, the studies suggest that the desired effect to produce chloroquine needs a very high dose, which can be toxic, and therefore that is why it is not recommended now. There's a lot of talk about ivermectin. It is an in vitro action being blocking the nuclear import of viral proteins that suppresses the normal immune response. Other conjuncture mechanisms, including inhibition of SARS-CoV-2 activity, protease essential for viral replication. So basically, it affects the viral replication. But overall, the evidence also suggests that the early use of ivermectin may reduce morbidity and mortality, but the trials are being evaluated and peer-reviewed at the moment, and therefore it is still not recommended by the WHO. There is plasma exchange and monoclonal antibodies. The monoclonal antibodies is there, but the trials are going on, but it's been used in clinical practice. And plasma exchange with convalescent plasma, that is plasma obtained from infected patients, have also been tried, and there have been mixed results. So anticoagulation recommended for moderate to severe critical cases of COVID-19. Enoxaparin is a preferred low molecular weight heparin, and for high risk patients may consider post-discharge prophylaxis with rivaroxaban or apibactam. Those are the two drugs that have been preferred as the anticoagulants. So, so this is how you go by the protocol, the treatment available. Initial stage, day 1, mild, maybe up to day 7, the antivirals may be effective, but then the inflammation starts, then glucocorticoids, anticoagulation, and potential therapy with tocilizumab and other drugs which I have mentioned. So this is the usual. So this is the glucocorticoids in patients with COVID-19. In China, the initial trials, they use methylprednisolone. This is the dose they used, and some trials had shown some benefit, but the larger trial used dexamethasone 6 milligrams daily up to 10 days, and that is the recommended dose that have been used. So patients who are mechanically ventilated or patients who are on high oxygen demand, recommended against the use in patients who do not require supplementary oxygen according to these trials. So WHO recommends routine against the routine use of systemic corticosteroids for treatment of viral pneumonia. It's used only for patients who need oxygen. So these are the other studies in summary. Lopinavir and ritonavir are antivirals against HIV, no benefit. Hydroxychloroquine, as I mentioned, theoretically yes, but practically needs very high doses, so no benefit. Remdesivir completed trial shortened the time of recovery and therefore recommended. The second trial has been terminated with no significant benefits. Then this is another study, Comostat mesylate, it's ongoing at the moment. Then anti-inflammation tocilizumab, the trial completed, but it is being recommended. Glucocorticoids, dexamethasone has been recommended. So thank you very much.
Thank you, Professor Jayamana, for that very informative lecture. We have got some questions for you, but that we will be discussing after the session. Let me introduce our next speaker, Dr. Indika Boteju. He's a consultant physician in Castle Street Hospital for Women. He's been involved with looking after a lot of COVID patients in the Castle Street Hospital. If there are questions, please do not hesitate to send us in. So we'll have a discussion after the whole session. So let me invite Dr. Boteju for his presentation.
At the outset, I would like to thank the Council of Perinatal Society of Sri Lanka for organizing this webinar. And special thanks goes to Dr. Sanathan Roll, President of Sri Lanka Society of Perinatal Society, and Dr. Professor Rasika Herat for organizing this. And this is the outline of my talk for the next 20 minutes. I'm going to talk about categorization of the COVID-19 disease and management of asymptomatic to severe ill patients, and oxygen therapy in COVID pneumonia with pregnancy, and a little bit about patient self-induced lung injury, which is a new theory at the moment, and place of awake prone positioning and use of IV Toziliuzumab, anticoagulation in pregnancy with COVID-19, dynamics, and other supportive measures. So, categorization, as you all know, 70% of our patients are asymptomatic, and there's mild disease or symptomatic disease with flu symptoms without shortness of breath or dyspnea, maybe about 80%. And moderate disease, of course, we define it as having desaturation 90 to 94%. Without increase of work of breath. So, when the work of breath is mainly we define by the respiratory rate. If it is less than 30 with desaturation less than 94 in non-pregnant women, less than 96 in pregnant women, we take it as a moderate disease. So, just please note that for pregnancy we take the cutoff value for saturation as 96%, since we want to avoid hypoxia to the fetus. Severe disease is defined by having desaturation less than 90% as a standalone criteria. Can have 90 to 90% desaturation as well, but the patient will have then increased work of breathing with chest X-ray involvement more than 50%, and vitals also may be unstable. So, when the patient is having severe disease with multi-organ involvement, we call it as critical disease. So, asymptomatic patient management, of course, there's nothing much, but it's very important because we have to monitor this patient for the development of moderate or severe disease. So, for the monitoring, we do basic investigations initially before discharging, and we do MED test, which is called modified exertional desaturation test. So, I will talk about MED test in the next slide, and usual monitoring we do, and hydration we do with the adequate nutrition, and we have to look for warning features before discharge like difficulty in breathing, chest pain, heaviness, confusion, and obviously the saturation level. Management of other medical obstetric and medical conditions is where paramount important. Some patients are asymptomatic though they have medical and obstetric complications. So that those patients also we can't send for home-based management. Continuation of low dose aspirin is recommended. Actually, starting aspirin, if appropriate, for these patients who are having risk factors like hypertension, type 2 diabetes, obesity, and dyslipidemia, is actually recommended even for asymptomatic patients. So, modified exertional desaturation test, which is called MED test, this is a validated test in COVID-19 pneumonia to identify subclinical COVID-19 pneumonia, viral pneumonia at the early stage. As you heard, we can find out whether the patient is going into immune phase or not with the development of viral pneumonia, so that we can start the treatment for these patients at an early stage than later. So, MED test, how we do it is, this is indicated for patients who are having saturation more than 96% on room air, and we get the patient the resting saturation, oxygen saturation, and then we ask the patient to sit and stand repeatedly within 1 minute. Then after 1 minute, we wait for 30 seconds for her to be seated, and then measure the saturation again. And if the saturation is less than 96%, In pregnant women, we take it as positive, and if it is less than 94%, non-pregnant women, we take it as positive. So, management of patients with mild disease is again mainly we have to monitor this patient whether they are going to develop moderate or severe disease. Apart from that, if the POA is more than 24 weeks, we observe at least for 10 days if they are having mild symptoms. Because in pregnancy, symptoms are not that marked, and the data has shown that pregnant women do not show clinical features that much compared to the non-pregnant women, and but they are prone to have high incidence of critical illness and HDU and ICU care as well as mortality. So, because of that, until the last guideline given by the MOH, Ministry of Health, we were keeping patients having POA more than 24 weeks until 10 days, irrespective of their symptomatology. And we do the basic investigations with the med test daily to find out early pneumonia, and start symptomatic treatment for these patients and continue aspirin as I informed. And then we start subcut enoxaparin prophylaxis dose if the POG is more than 24 weeks, because pregnancy is a prothrombotic state and COVID-19 also prothrombotic state. And when we do the full blood count and the blood pictures, we see most of the patients are having mild thrombocytopenia, but the blood picture shows platelet clumps. That means there should be clumps in the microvascular also. So there's a high tendency for these patients to have thrombotic complications. So the subcut enoxaparin prophylaxis dose is indicated as per guideline. We will discuss it later. Then for moderate disease, so moderate disease is defined as patients who are having saturation 90 to 94% with or without oxygen, and these patients have increased, not having increased work of breathing, but they are desaturating. So these are the kind of patients who are in the ward. So in the ward, we give some oxygen, 2 liters, 4 liters, and the patients are having pathophysiologically L-type lung without much features of increased work of breathing. So these patients, when they come to moderate disease, that is with the desaturation, we have to start triple therapy and triple measures, triple maneuvers. So triple therapy includes IV dexamethasone, as we discussed earlier, 6 milligram per day, up to 10 days or until we discharge the patient. And we start IV ceftriaxone 2 gram per day as per guideline if it is indicated if we suspect bacterial infection. Anticoagulation with subcut enoxaparin 40 milligram daily is indicated. If enoxaparin is not available, subcut heparin 5000 units BD is indicated. Triple maneuvers indicates strict bed rest and pre-oxygenation before exertion for these mothers. Because we have seen patients with moderate disease having 90 to 94% on oxygen, and they remove their oxygen mask and or the nasal prongs, and when they exert, their saturation goes down to 80s and 70s and they collapse. So this is part of a happy hypoxia, having severe desaturation when on exertion while on oxygen. So because of that, we promote them to have pre-oxygenation before exertion, at least for 20 minutes, about 5 liter oxygen before going to the washroom, and come back and then rest. And we recommend strict bed rest for these patients as in dengue. And cyclical proning or the awake proning, we will discuss it later again, which has shown very good benefits with regard to improving hypoxia in these patients. And definitely oxygen therapy when the saturation is less than 96% in pregnant women, and when it is less than 94% in non-pregnant women. And we do lab investigations as we said earlier, full blood counts, ERP, LDH, and serum ferritin, renal functions, liver functions with procalcitonin and D-dimer levels and IL-6 levels if it is indicated. Mainly we monitor these patients for increasing of work of breath and rising of oxygen demand. So if the patient's work of breath is increasing and if the oxygen demand is rising, it indicates that this moderate disease is progressing into severe disease. With that, our management is going to be changed. So when the patient is having severe disease, then the patient will have less than 90% oxygen saturation as a standalone criteria, or else the patient can have 90 to 94% saturation with increased work of breath with a respiratory rate of more than 30. So we continue triple therapy and the triple maneuvers, and we need to have HDU ICU care for these patients because they will need increased oxygen flows. Then appropriate oxygen therapy and therapeutic anticoagulation is indicated. Actually, at this point, we have to switch to subcut enoxaparin intermediate dose, that is 40 milligram twice daily as per guideline. And we do continuous monitoring in the HDU, and probably we have to decide to give IV Toziliuzumab, so that if facilities are available, we have to do IL-6 levels too. Because this could be bacterial pneumonia, the progression could be due to the bacterial pneumonia, progression could be due to the COVID pneumonia, could be due to the patient self-induced lung injury as well, which we will discuss with time. And it will be high time to consider MDT meeting to decide on giving Toziliuzumab. As we said earlier, the timing is very important. If we miss the timing for IV Toziliuzumab, we might not get the most benefit from the drug. Sometimes it might harm the patient also because it will expose the patient for severe sepsis. And at the same time, we have to look for other organ involvement and given the necessary organ support. And maybe we have to arrange MDTs for consider delivery plan of the baby as well as early or planned intubation than late. So oxygen therapy, it depends on the device, flow rate and the FiO2. FiO2 depends on the flow rate, that is the rate of the oxygen we give, and the type of the delivery device we use. Usually in our ward setup, we have flow meters. That device delivers 100% oxygen. But from the flow meter, we connect either to the face mask or nasal prongs. With that, our delivered FiO2 differs depending on the device. So additional air volume is added from the surrounding to the device. Because of that, FiO2 varies. So the methods of giving oxygen varies depending on the type and the flow rate. So we give a conventional oxygen therapy in the ward where we have moderate patients, and for severe patients they are in the HDU where we need high flow oxygen. So that is high flow nasal oxygen. It could be CPAP, it could be BiPAP or invasive ventilation or ECMO. And conventional oxygen therapy in the ward, we have a few options. Nasal prongs where we can go up to 1 to 5 liters, more than 6 liters not recommended by the nasal prongs. And to start up, it's a good way because it's easy for the patient, and the patient can wear the face mask too. And if we can't achieve our targets with the nasal prongs, then we have to go for the simple face mask with 6 to 10 liters, can go up to 15 liters also. But 6 to 10 liters is the recommended. If it is not improved with the simple face mask with 6 to 10 liters of oxygen, then we go to NRBM, non-breathing mask, with a high oxygen flow rate, that is 10 to 15 liters per minute. And if you want to give a higher FiO2 value, best option would be to use face mask with Venturi device, where we can use up to 60% FiO2 with the green device, and with there's the desired oxygen flow rate is marked on the device. So we have to make sure that the designed rate is being given with that device. With this COVID-19, for oxygen delivery, high flow nasal oxygen machines are getting more popular because it is very user friendly and very convenient for the patient, and we don't have to wear the big mask as in CPAP and BiPAP. and its presentation of oxygen is via a nasal prongs. And if we are using this, we have to consider about 3 settings in this machine, which is one is temperature. We have to put it as for 37 degrees, and if the patient is not comfortable with that, there's a range from 32 to 37. Flow rate, we can start with 15 liters per minute, which can go up to 60 liters, and FiO2 with the flow meter, we can change up to 21% to 60%. Make sure once you use this high flow nasal oxygen machine for a patient, after using one patient, to disinfect the circuit for the next patient, because if you without disinfecting, if you use it, then the machine itself will ask you to disinfect the machine, and it will take about 50 minutes to disinfect it. So you can't use it in a acute setup. CPAP and BiPAP machines are available, and there are 2 types, dual limb machines and the single limb machines. Dual limb machines, you have the port for the exhalation, but in single limb machines, make sure that we use the non-vented mask, because if you use a vented mask, the patient's expiratory air will come out, and there will be droplets going out from the mask to the surrounding area, then the staff is at risk. So use a non-vented mask, and if you are using an unvented mask, make sure that there is a viral filter down, and then after the viral filter, down to that, there should be a exhalation port for the patient to remove the exhalation air. Otherwise, patient will suffocate with the CPAP machine. Here also we can give high flow oxygen with higher FiO2 values. Now suppose if you get a mother with a saturation less than 96%, what should we do? So look for work of breathing. Work of breathing includes respiratory rate. Usually if it is, we take it as if it is more than 30 per minute, it's high work of breathing, less than 30 low work of breathing. It says there's some scales also, 20 to 25 you give 1 mark, less than 20 1 mark, and 25 to 30 1 mark, above 30 1 mark. So 4 marks are there. And in addition, if the patient is using abdominal muscles, we give 1 mark, and then accessory muscles of the neck, if it is being used, another mark, and if the nasal flaring is there, 1 mark. So altogether 7 marks are there when the patient is in fully loaded with work of breathing. So if the work of breathing is normal, that is as per guideline, if the respiratory rate is less than 30, you can start giving low flow oxygen, which is via nasal cannula up to 5 liters. Suppose if you can't achieve the saturation 94 to 96%, you can add face mask, change to face mask, and increase the flow rate up to 10 to 15 liters per minute. And if that is also not satisfactorily control the hypoxemia, you can go into face mask with venturi device, or you can straight away go for non-rebreathing mask with 15 liters of oxygen. And so for this actually with one device, just try with about 15 minutes and don't waste time. And then if with this also the saturation, if we can't achieve more than 94% to 96%, then OS, if the patient coming with increased work of breathing, then you have to consider non-invasive ventilation in the STU setup, where you can use either HFNO, high flow nasal oxygen, up to 60 liters we can use, but you can start with the 15 liters with a low FiO2 value, maybe 30 or 40. And then if it is not available, you can use CPAP, or depending on the availability, BiPAP, whatever available you can use. And try to make the patient, treat the patient's hypoxia without delay within 1 to 2 hours. So if within 1 to 2 hours, if the patient is still having increased work of breathing and hypoxemia, it is more likely that patient will develop self-induced lung injury, which is not COVID pneumonia, which is not bacterial pneumonia, which is not pulmonary embolism, but patient will have lung damage. So because of that, make sure you treat the patient appropriately and urgently for these patients and achieve your targets and try to reduce the work of breathing of the patient, which is very important. If it is not achieved, then we have to decide of early or planned intubation if it is necessary with the consultation of the anesthetist, and then if following intubation, especially when the L-type lung is having the H-type lung with a picture of ARDS, then there may be very severe hypoxia which is refractory to intubation as well. Then of course other end is referral for a early referral for a veno-venous ECMO. So what is patient self-induced lung injury? That is called P-SILI. So this is induced by persistently strong spontaneous inspiratory efforts by the patient. So there will be increased work of breathing, which we have seen, and because of this increased work of breathing, there will be increased respiratory drive and tidal strain to the alveoli. There will be increased tissue stress, and transcellular and vascular pressure will be increased, and there will be rapid progressive deterioration of lung function because of this increased work of breathing. So how to treat this? So we have to deactivate the cycle. So how to deactivate? Either you have to increase the oxygen flow, we have to give high flow oxygen, maybe nebulization. If not improved, then we will have to consider intubation. So that is why now there were two schools of thoughts about intubation, late intubation or early intubation. We know that late intubation have given rise to high mortality. So now we are considering about early intubation of these patients to prevent P-SILI. So when to intubate, as you said, as we know, timing of intubation could change the outcome, and mortality is high in intubated patients, and because of this we have to observe the increasing work of breathing of the patient. If it is increasing and if the oxygen demand also increasing while on NIV, please consider intubation early. And ECMO, it's not widely available in Sri Lanka, only 2 centers. Just for completeness, it is a way of drainage of deoxygenated blood from the large vein, and then we externally oxygenate the blood and then return it back to the right atrium. It is not easy as we talk. It needs so much human resource, and it needs so much monitoring and support. It's not easy. So what is the place of awake prone positioning in these patients? And this has shown to increase ventilation perfusion mismatch of the patients and improve perfusion. So because of that, we have seen most of the patients with this awake prone positioning changes, and the oxygenation improves very dramatically. We ask the patient to lie on right lateral position for about 30 minutes to 2 hours, and then to sit up in a prop up position 30 degrees to 60 degrees for about again minimally 30 minutes, and then left lateral position, and to change again to fully prone position. So there are relative contraindications and absolute contraindications. Relative contraindications includes advanced pregnancy. So it may be difficult for some mothers with the gravid uterus, but for the POS less than 24 weeks, we can do this. If the patient is hypoxic, as well as we can do this procedure while the patient is on NIV as well. So what is the place of IV Toziliuzumab for these patients? It is, as we heard, interleukin 6 inhibitor, and it has to be a MDT team decision to give IV Toziliuzumab with increasing oxygen demand and failure to steroids and increased work of breath. So this is basically when the patient is having COVID pneumonia and with the cytokine storm. So we have to exclude bacterial infection and other viral infections. So that's why we are doing procalcitonin. If the procalcitonin is high, it indicates bacterial infection, and if you give Toziliuzumab, that will harm the patient. And the CRP has to be more than 75, or doubling CRP should be there within 24 hours with high LDH, ferritin, and IL-6. If you have facilities to do it, you can do it from private sector. So the dose of IV Toziliuzumab is 8 milligram per kg up to 800 milligrams, the maximum dose. We can observe the patient for the first 24 hours, and within next 12 hours, if the patient does not improve or if patient deteriorates, it is you can use a repeat dose for these patients. After 24 hours, time period is gone. So because of that, we have to have a MDT meeting and to decide on the timing and the appropriateness of treating with interleukin 6 inhibitor Toziliuzumab. Otherwise, a patient will have a septicemia, and we might harm the patient also. There are contraindications for Toziliuzumab. Obviously the sepsis, and then having thrombocytopenia, platelet count less than 50,000, and having severe neutropenia, and if the ALT is more than 5 times the normal, the upper limit. So what about anticoagulation in pregnancy with COVID-19? There are several guidelines, and our Sri Lankan College of Hematologists, they have given guidelines for pregnancy and anticoagulation with COVID-19, and RCOG guideline also discuss about anticoagulation in pregnancy with COVID-19. So according to RCOG guideline, all pregnant women with COVID-19 should be anticoagulated for the DVT prophylaxis until they are in the hospital, and after discharge for 10 days. And even in the postnatal period, if they are presenting within 6 weeks, if they are readmitted, we have to anticoagulate for DVT prophylaxis, and then after discharge for 10 days, we have to give DVT prophylaxis. So our Sri Lanka College of Hematologists, they have guided us for the standard prophylactic doses for enoxaparin. So that is for prophylactic dose, they recommend is 40 milligram daily, and for intermediate dose, where we use it for severe COVID patients, we use prophylactic dose given twice a day, that is 40 milligram twice a day. And therapeutic dose of enoxaparin is the same as for other patients. Sometimes these patients having thrombocytopenia, if the platelet count is less than 50,000, therapeutic dose, that is BD dose, is contraindicated, and if the platelet count is 25,000, prophylactic dose, that is daily dose, is contraindicated. But otherwise, you can use, if the platelet count is 75,000, still these patients giving anticoagulation is beneficial. So what are the other supportive measures? Mainly fluid management. These patients, they have loss of appetite, severe loss of appetite. They are coming with tachycardia, hypovolemia, hypotension. So make sure we rehydrate them with oral rehydration therapy, or else appropriately with IV normal saline. And we have to manage sepsis accordingly. Maybe other sepsis, we have found UTIs and other pyelonephritis and other infections, even dengue. So look for those. And glycemic control is mandatory, because the fetus can have fetal macrosomia or polyhydramnios with poor glycemic control. So we have to give either metformin or insulin. So it's not easy managing these patients inside the ward, giving insulin 3 times daily and doing blood sugar series. It's really difficult, but still you have to do it. And acute kidney injury and liver involvement and CNS involvement, cardiac involvement, we have to look for, together with appropriate nutrition for these mothers. So I think we discussed about the available treatment and other treatment considerations. For the interest sake, remdesivir is we are not using in Sri Lanka here in the government guidelines, though it is recommended in the WHO, and not much evidence for pregnancy also. Baricitinib, that is Janus kinase inhibitor, it is an oral medication which is not available in Sri Lanka. And hydroxychloroquine is contraindicated at the moment, don't use. Azithromycin, you can use it if there's an indication, and if you suspect bacterial infection through throat, then it's a immunomodulatory effect also there. So may be beneficial, but evidence is not that concrete. And ivermectin is not to be used as per our guideline, and still we are lacking enough evidence. Vitamin D, vitamin C and zinc, yes, you can, it's there in our guideline to use if the treating physician desires to give, but evidence is not that convincing. So the take home message is monitor each pregnant patient individually, closely, daily with history and observation and investigations. So which is very important to pick up the early pneumonia and treat these patients, and to see whether these patients are going to develop moderate or severe infection, and detect the initiation of viral pneumonia early, so that we can give treatment early and prevent deterioration. And patient specific individualized management should be done for each patient. We can't give a blanket management for these patients since they are pregnant also. And please look for atypical presentations, anticipate and look for atypical presentations, and please provide adequate protection to your staff and give psychological support to them as well, because they are doing a great job. I think that ends my talk. So we are happy to answer any questions at the end. Thank you.
Thank you very much, Dr. Boteji, for that very informative presentation. Next, we are going to invite Dr. Harendra Dasanayaka. One of the main problems that practicing obstetricians and obstetric teams island-wide has is that when we get a call from a patient who is found to be COVID positive with symptoms, where to look after, how to look after, and so on, how do you find an ICU bed, a lot of questions. Now, Dr. Harendra Dasanayaka is a consultant physician working in Family Health Bureau, and he's ready to answer most of these questions. He'd be talking to you about how can the health system helps you in managing COVID women with pregnancy. Over to you, Dr. Janaka.
Right. Thank you, Rasika. I think we are more in a general discussion than the previous two presentations here. So we'll be discussing how the system supports the management of COVID-19 pregnant mothers and neonates. So it's obvious now, looking at the situation, country situation 1 year back or 1.5 years back, the stress, the more important things for the health system was not at all COVID. So there were more important things, and the focus was on other things. So when it comes to this stage, where the focus is mainly on COVID, we have to understand that the system, the health system, had to go through so many changes to provide care for these this pandemic and the affected persons. So now, regarding the management of COVID-19 mothers and neonates and patients in general, the main focus for the clinicians, it's looking after the patients. But for the health system, it's one part of the management system, and the other part is prevention. So these two have to go hand in hand in order to prevent, to battle this pandemic. So now for the system, it's a big burden. For the health system, it's a big burden. Now, as we discussed earlier, you might have heard about all these sophisticated management modalities, and then the drugs, then the laboratory testing. All these things, they were not the focus earlier. So the health system was not ready for this. So in Sri Lanka, we are with the economic status being like the middle income, the allocations for these services was not planned for COVID management. Now, at the beginning of the last year, it was only one patient, but now, as you know, the numbers is massive. And regarding the maternal and child involvement, now during the first two phases, the number of mothers affected by COVID was very minimal. But in this third wave, it's a massive number. Numbers go up to more than 3,000 at the moment. So with these massive numbers, other than providing the normal care for the mothers, maintaining those services also, providing these additional COVID-related services has become a burden. So we have to have the health system is evolving to provide these services. And one of the main things is the governance. So we have to support and get involved in policy making. The system is, it's happening every day. The policy decisions has to be made and support implementation of these policies. So, to do this, the system has to get involved in all these COVID-related management platforms. All these decisions has to be made not only by the health, but also with the support of the other sectors, maybe the armed forces and the other stakeholders. All these people have to be involved. So this is one of the parts the system supports, where system supports for management of COVID-19 maternal and child cases. Then administrative support to improve the facilities. This is one of the most important things, because as we discussed now, for example, wall oxygen, then these ICU facilities, HDU facilities, these things were not the focus, for management of normal patients. So for COVID, it's mandatory. So we have to improve all these services. So identification of different levels of care institutions within regions. Now this is one of the things this system has introduced, where now at the beginning the patients were all sent to the central level for management. Now this, with the increasing caseload, it's not practical to get all the patients to Colombo or the places where specialized facilities are. So we have identified a system where 3 levels of care is identified, level 1, level 2 and level 3, where the level 3 is the highest level, where all these specialized hospitals, then district general hospitals, these hospitals care for critically ill and difficult to manage patients, while the level 2 and level 1 will provide care for non-critical and less complicated patients. So in the earlier period, where the numbers were less, the plan was to have all these mothers who are pregnant to an institution and give institutional based care, but the policies have changed and the guidelines have changed by this moment, where the mothers are being cared at different levels, and some mothers now at the latest stage, some mothers are being provided care at the home-based level. So this is one thing. Then provide assistance and supervision, do assessments and supervision of care institutions for facilities. Now we have to, the system has to visit and look at these available services and see what has to be improved, what are the areas need to be improved. So we need to improve the isolation facilities, then investigations. Now I don't think people were much aware of this PCR until COVID came. So these things are now, they have become a day-to-day thing. So providing this care and assessing the available care services and then trying to improve these with the support of the regions and the central level and maybe the donors and all. This has been happening all throughout. That is how these systems have improved so much to care for COVID patients, even critical patients at district levels without the patients coming into the central level. Then looking at these supervision and assessments, the recommendations had been made to different levels up to the higher authorities of the Ministry of Health and then the politicians, then the government representatives. All this has been done through the system. Then with that, we have to get the funds allocated and provide the optimal care. Then of course, staff and other resources, especially the staff, because training staff is not practical. In a situation like this, we have to do it, but then you can't create these staff positions and trained staff within a short period. So what we have to do is utilize the staff in the most effective manner, using the staff who are trained to places where the need is more. So this is one of the parts the system supports for the management of patients with COVID. Then optimize service delivery. So optimize service delivery settings and platforms. So that is what we have been discussing. And then establish effective patient flow. Now that is another thing, because patients, they come with sort of different complaints and they appear in different places. So these patients have to be properly directed and referred to the needed services. Sometimes there may be a patient who's not very critically ill, but in a tertiary level institutions where there are other patients who need this more sophisticated care. So in situations like that, it's important to identify the need and do proper referrals. So this has been done through several points, and that will bring down the burden on the clinical teams, because all the necessary people will be in at the necessary the most required places. So then redistribution of healthcare workforce. Now that is another thing, again we discussed earlier, because rather than creating new healthcare personnel, we have to use the people who are within the system who need to support the other centers where there are so many COVID centers established island-wide. So these places need now, say for newborn care and maternal care, there are special trained personnel. So these people have to support, otherwise we can't create those trained staff immediately. So what we do is we use these staff from the center now. For example, the neonatal teams from the Castle Street Hospital used to support the Mullaria Hospital for when the need came up. So that sort of decision making need to be done through the system. We can't haphazardly do that. So if the need is there, the request must come, and then we need to mobilize these trained staff for the proper use of their capabilities. Then mechanism to maintain the flow and distribution of essential supplies and equipments, liaising with the service delivery platforms. Now that is again very important, because sometimes these equipments, they may be idling in some places when the need is more at the other places. So we have to identify these places and properly distribute these supplies and try to provide maximum use. Then providing support to the clinical services. Now, even the earlier discussions were like that, and when we talk about providing equipment, we have to identify the need, we have to support, we have to find the funds, and then support the places where it's needed most. Then develop patient management guidelines. Now, this is also very important because these guidelines has to be now when such a lot of patients are coming in, we have to adhere to guidelines, and these guidelines should be patient friendly as well as the carer friendly. So these guidelines need to be properly done and properly formulated so that it can be used at all places. So this task is done through the system with the support of the professional colleges, of course, because without the professional colleges we can't do it alone. So the system provides these facilities so that the patient management is basically being carried out in a uniform manner in all institutions. There may be personal expertise and things, but then the guidelines will guide you to the proper management. So that is happening. Then identification of different levels of care, as I discussed earlier, that is being done. So this is providing the clinicians less burden to now say, for example, when we admit a mother, if the mother is COVID positive, this mother, the guidelines said the patient should be there for 10 days in hospital. So in a tertiary care level hospital, having a patient postpartum mother without any complications is not easy, because there are other patients coming in, because it's a place of excellence. So in that case, we have identified the step down care where the patient, if the clinicians are satisfied with the patient's condition, the patient can be sent to a lower level institution where the mother will be still cared for, and the complications will be, not the complication, the clinical condition will be discussed with the clinicians and the proper management will be done. And the supportive services, ensure the availability of other supportive services. So patient management is not only the clinicians and the doctors, but there are other supportive services like the blood bank services, then laboratory services. All these services have to be properly arranged so that these patients get the optimal care and their investigations are available in time, and all the drugs and all these things are available for the optimal management of patients. So these things have to be coordinated properly. So the system is doing that. System is doing coordination. There may be instances where with the increasing patient loads, there may be instances where we have to improve more. But then from the initial stages up to now, we have improved a lot, and we are still in the process of improving, because we never know whether there will be a fourth wave. So, and the next one is improving the public health services. Now, for patient identification, there are various ways of patient identification, doing these random tests. Then when the patients present with problems, now especially maternal and child cases, especially they have a tendency to keep a good rapport with the public health teams. So the public health midwife, the MOH team, these teams are aware of these patients more. They have a good rapport and a good relationship. So we have like made a pathway for the patients to come in and get themselves checked if there are symptoms, and then to be referred to the proper care. according to the say a mother, according to the period of amenorrhea, then according to the comorbidities they are having, the patients will be directed for the optimal care. Then providing quarantine facilities, we have intermediate care centers and then level 1 institutions for maternal care. We did not recommend to have these mothers at intermediate care centers, but to have them in level 1 facilities. So that has changed now. These care facilities were provided by the services, the authorities, so that they get the optimal care and timely care. But still, there are instances where we miss the patients at the right time. Then, with this COVID pandemic, still the care for the pregnant, postpartum and neonatal, the child health services through the routine public health system is happening. Maybe not up to the standard the way it used to be, but still we are ensuring, the system is ensuring that these things, the routine care is happening, so that we are able to identify any problems with these patients, maybe after becoming positive, going back to the community or even at the community level. So we are ensuring these services now with the vaccination and all these other added workload. Even with those workload, we are trying, the system is trying at its best to provide the routine care facilities. So the vaccination, child vaccination, EPI program, all these things are still functioning despite the COVID situation. Then the system is trying at maximum to provide, make awareness within the general public, and using the media and then webinars like this, and also through other small discussions to make awareness among the general public regarding this the COVID pandemic, and to use all these precautionary methods and using face masks, all these things. We are trying to make awareness among the general public as well as the pregnant mothers, because we see sometimes we see that people are not adhering to them and they become infected, and it's a big burden to the system as well, not to mention to the families and the affected. It's a big burden to the system as well. Then regarding the surveillance system, now Sri Lanka has a very good maternal and neonatal death surveillance system, especially a maternal death surveillance system. And now the system has to be improved to carry out special surveillance for these pregnant mothers. Unfortunately, there are mothers dying, and up to now we are having more than 30 maternal deaths due to COVID. So all these deaths are being, the surveillance activities are carried out for all these deaths, and then the recommendations which comes out with these after discussing all these cases are being used for the improvement of the system to care for the patients. So what sometimes these discussions have shown that the delay one, where the patient seeking health care when they become ill, is one of the main causes leading these mothers to death. So we are conducting these surveillance programs for the mothers and children, maternal and child deaths, to identify the causes, identify the possible risk factors, and then make recommendations and provide advocacy based on these findings to improve the system, improve the services available, and to make awareness about, among the mothers and the public. Then if we discuss about the home-based management, which is all these things are circularized and the guidelines have been issued. So home-based care, home-based management is one of the new things where the patients will be identified and they will be assessed and they will be introduced to a system where the system will be looking at the patients in a daily basis. A group of healthcare professionals will be looking at the patients through in a virtual manner, and their status will be updated and they will be managed and they will be advised, or they will be referred to institutional care if needed. So this is happening even for the pregnant mothers. It has been identified home-based care where can be done with the help of the obstetric teams, with the opinion of the VOGs. The patient can be assessed and then managed at home if there are no comorbidities, and if there are no other risk factors, the patient, and not symptomatic patients, they can be managed at home. And if there are symptoms, they can always be directed to the hospitals as they require, based on their requirement. So apart from the central system where the the health ministry centrally conduct this system using this 1390 call center, district-based facilities also have been established as different places to provide for the mothers and the children in those areas. So that is being done, and that is the new trend, the home-based care. But still, you have to be aware that if there are symptoms, you have to contact and you have to get the opinion, and you will have to go to the hospital if needed. That is, if needed. So and then the system allocates resource for this home-based management, because it's not easy calling all these mothers and children, or even the other parties. Mothers and children are one of the only part of the group. Other patients also, for home-based care, we need to identify resource persons and allocate them to provide this care without interruption whenever they need it. And then regarding the vaccination of pregnant and breastfeeding mothers, with the help of the professional colleges, these guidelines have been developed and vaccination has been started. Now at the moment, vaccination is being done for all pregnant mothers, irrespective of the period of gestation, and vaccination is being carried out for all these mothers at different centers. Now this has to be arranged so that the mothers get the vaccination without any delay and without any sort of contamination by getting in a queue and doing it. So the system is introducing different methods, maybe at the this has been discussed at the clinic centers, or and this when vaccinating, we have to have the proper environment and the proper facilities to provide care if there is any reactions. So these things are being guided by the system, and we try to provide the maximum care for these mothers. Then we have to maintain the manpower and other services. We have to maintain call chain. we have to do all these things. So the system is providing the necessary equipment and the manpower, and then we have to ensure the availability of vaccine stocks for all pregnant mothers. So these things are being monitored, and then the estimates are being made, and the vaccines are provided for all these mothers, and the coverage is satisfactory at the moment, and it's being done throughout. So we get questions whether the vaccination can be done for all mothers. Is there a gestational age barrier? So we had earlier something like that, but at the moment the guideline is you have to vaccinate all mothers irrespective of the period of amenorrhea. So these are the things that the system does, and all these are in circulars and guidelines. You can go through any of these, and if there are any clarifications, you can discuss with your regional healthcare providing administrative bodies, or the special programs, or the center. And the patient management and allocation of hospitals for patients when needed is being done by the health ministry itself. And if there are any issues, you can always contact and find out what you have to do and what you can do. So that's the end of my discussion. So if there are any questions, we can discuss later. Thank you.
Thank you, Dr. Harendra. Our next speaker is going to talk about the newborn. She is Dr. Shama Basnayaka, consultant neonatologist from Ledridge Hospital. She's been involved in looking after neonates of COVID mothers for a long time, and she's been very helpful to most of the obstetricians who is looking after pregnant women with COVID around Colombo. It's over to you, Shama, to discuss about how to look after a baby of a COVID-19 pregnant.
First of all, let me thank the Perinatal Society of Sri Lanka for giving me this opportunity. We have discussed about the pathophysiology and the management of pregnant women with COVID in our previous lectures. So I'll be moving on to neonatal care of babies born to these COVID positive mothers. So my topic is how to look after a baby of a COVID-19 positive mother. As we know, the number of mothers with COVID-19 infection is rapidly increasing. And in this unfortunate situation, it's our responsibility to look after their precious newborns. Current data suggest only 1.62% of babies get infected during the first 1 or 2 days if the mother is positive at the time of infection. This risk is even lesser if the mother has tested positive 14 days prior to the delivery. So that means the risk for the newborn is very less. But we have observed increased frequency of preterm births, low birth weight babies, increased rate of cesarean section, and increased rate of NICU admissions due to this COVID positive mothers, COVID positivity in mothers. How do these babies get infected? There are 3 potential mechanisms of maternal transmission to the newborn. Intrauterine. Intrauterine transmission is not very common. It's a rare mode of transmission. It can happen through placental hematogenous spread or inhalation of or ingestion of viral particles in the amniotic fluid by the fetus. Though it's rare, there are reported cases of intrauterine infected babies. Intrapartum transmission, where baby is getting infected at the time of delivery. When baby is exposed to infected maternal secretions or feces, baby can get the infection. This postpartum infection, postpartum transmission is thought to be the most common mode of transmission, where once the baby is born, when we keep the baby with the mother, baby can get infected from mother's infected respiratory secretions, or from other infected healthcare workers or household workers when they are exposed to the baby. Although we say the risk of infection is quite less in newborns when the mother is positive for COVID, we should keep in mind all neonates born to mothers with COVID-19 infection should be considered as babies suspected to have COVID. So, we need to treat them in an isolated area until we prove they are not infected. Having said that, we shouldn't compromise their care. These newborns should not, the management of these newborns should not be delayed under any circumstances pending COVID PCR results. All these newborns should receive the usual standards of care in keeping with their clinical status in a designated area. Let's move on to delivery of a newborn of a mother with COVID-19. The rate of infection in neonates do not appear to be affected by the mode of delivery. And the neonatal clinician should attend the delivery depending on their hospital specific policies. The COVID positive pregnancy alone is not a specific indication for this purpose. Minimum number of healthcare personnel should be in the delivery room, and they all should be in full personal protective equipments. As we know, sometimes baby might need respiratory support or any resuscitation. These procedures might generate aerosol containing virus particles. If a baby needs respiratory support in the form of bag and mask ventilation, it is always better to use two-person technique. Then one provider can hold the mask tight in order to prevent air leaks through the mask, and the other person can give ventilatory or inflation breaths. What do you think about this delayed cord clamping, skin to skin care and early initiation of breastfeeding among this group of babies? Yes, it's recommended because the benefits of these procedures, there are well established benefits of this delayed cord clamping, skin to skin care and early initiation of breastfeeding. So, we should promote these practices because the benefit outweighs the risk of transmission to the baby. Once this baby is stabilized in a labor ward or theatre, we should arrange the transport to a isolation area. We should use a predetermined path to transfer this baby, and baby should be transferred in an closed incubator to minimize the risk of transmission to the other patients. Always we should try and keep baby and mother together in an isolated area. Now, what about testing recommendations? All babies born to a mother with COVID-19 infection should be tested for COVID infection. The test is COVID PCR. It should be done ideally within 24 hours. The sample collection should be done by a trained nursing officer or a doctor. They should collect the secretions from the nasopharynx of the baby, and it should be transported in a viral transporting media. If this PCR test results done within 24 hours become negative, you should repeat the test in 48 hours or prior to discharge. If the baby is symptomatic, anyway, you have to do a PCR within 24 hours. In resource limited setting, in asymptomatic babies, we can delay the test and at least one PCR should be done within 10 days. Let's look at the care for a term clinically stable babies. This is the case most of the time. Most of these babies born to a COVID positive mother either asymptomatic or they are having mild symptoms. So as I said earlier, delayed cord clamping, skin to skin care, rooming in with mother should be encouraged, but keeping in mind there is a minor risk of transmission of the disease. What about breastfeeding? Breast milk does not transmit this virus from mother to baby. If at all, breast milk can give the baby a protection through antibodies. And considering nutritional, immunological and developmental benefits of breastfeeding, we should encourage mother to breastfeed her baby if clinically permits. If baby or the mother is unstable, you won't be able to breastfeed, but in every possible occasion, you should encourage and feed the baby with mother's milk. So, baby should not be separated from the mother. At the same time, we should try and minimize the risk of transmission from mother to baby. For that, mother should wear surgical mask and she should practice hand hygiene. But we do not recommend plastic face shields, face mask to be placed on baby's face. If possible, we should keep baby's crib at least 6 feet away from infected mother's bed. These measures will help to reduce the transmission of infection in a postnatal setting. How do we care for a preterm or a medically unstable baby? Where the problem comes, we have to face a lot of problems in this situation because we need NICU facilities. Every hospital should have a separated, dedicated NICU space to care for these babies, and once the baby is born, baby should be transferred immediately NICU and PCR should be performed immediately to confirm the diagnosis. If the initial PCR is negative, we need to repeat it in 48 hours. This group of babies most probably need respiratory support, either invasive or non-invasive. Once these babies are stabilized and their PCR reports are available, if it is negative, we need to transfer these babies immediately as early as possible to non-COVID ICU. Then let's look at babies with COVID infection. There are a group of babies who get the infection from mother and they show symptoms. How do we manage these COVID positive babies? They can present as early onset disease, late onset disease or multisystem inflammatory syndrome. So early onset disease, the onset between 2 to 7 days of birth. It is caused by perinatal transmission. Most of these newborns are either asymptomatic or have mild symptoms such as rhinorrhea, cough, sneezing, fever. But we have noted babies with moderate to severe symptoms such as respiratory distress, poor feeding, lethargy, vomiting and diarrhea. And there are babies with clinical evidence of multi-organ failure also. So, when we come across these babies, where our laboratory investigations will help us to come to a diagnosis, obviously positive PCR, and hematological test will show leukocytosis, lymphopenia, thrombocytopenia and elevated inflammatory markers. How do we manage these babies? Most of the time, only supportive treatment is enough. Appropriate respiratory support such as non-invasive CPAP, or if baby's respiratory condition is worsening, we have to escalate our respiratory support, and fluid resuscitation and fluid balance maintenance, temperature control and other supportive measures. We'll move on to late onset disease. The majority of these babies are diagnosed beyond 5 to 7 days of birth, they go home and readmit with the symptoms suggestive of COVID infection. Their initial PCR test before discharge from the hospital is usually negative, and on readmission they become positive. This group of babies also show moderate to mild symptoms, and apart from these hematological and biochemical investigations, they will show chest X-ray abnormalities as well. The management again is similar, mainly supportive. It includes supplemental oxygen, respiratory support, fluid resuscitation and temperature control. Evidence for use of antiviral medication and steroids in neonatal COVID is lacking, but there are case reports. They have used antiviral medications and dexamethasone in moderate to severe cases of newborns with promising results. Let's move on to multisystem inflammatory syndrome in children. This condition was initially described in children, but we have seen it in neonates as well. This is a novel condition following infection with COVID in children. This syndrome is characterized by fever, elevated inflammatory markers, and high levels of both pro and anti-inflammatory cytokines. They are presenting symptoms related to cardiovascular system, gastrointestinal system, or with mucocutaneous symptoms. Their investigation findings are quite deranged in these babies, so it will direct towards the diagnosis. Their hematology will show severe anemia, thrombocytopenia initial, thrombocytosis in early phase leading to thrombocytopenia, elevated inflammatory markers, then biochemistry will show hypoalbuminemia, elevated D-dimers, elevated ferritin, and severely deranged liver and renal function test. And echocardiogram will show deranged cardiac function. Currently, we are managing a baby with a multisystem inflammatory syndrome in our NICU at Lady Ridgeway Hospital. I will just briefly go through that case, then you will understand how the presentation and the management. So, this is a term baby born bilective LSCS with a birth weight of 4 kilos. This baby was discharged home on 3rd day after delivery and with uneventful postnatal period. He was readmitted on day 8 to the same hospital with shortness of breath, poor feeding and tachycardia. After their initial resuscitation, baby was transferred to Lady Ridgeway Hospital. So, on admission at our NICU, baby was tachypneic with a respiratory rate of 80, tachycardic with heart rate of 180 and saturation was 90 in room air, but blood pressure and circulation was fairly okay. Blood pressure was normal, mean arterial pressure, non-invasive pressure was 62 mercury millimeters and capillary refill time was 3 seconds, and baby had features of heart failure including cardiomegaly. So, our management at Lady Ridgeway NICU was, after the initial stabilization, we intubated the baby and ventilated due to the worsening respiratory status. Actually, our initial impression on the diagnosis was septicemia. So, we started broad spectrum antibiotics and we sent all the investigations related to that. So, in initial investigations revealed elevated liver function test, renal function test, neutrophil leukocytosis, thrombocytopenia with high PTINR. But repeatedly CRP was normal. And blood culture also subsequently came as negative. And chest X-ray revealed cardiomegaly with bilateral congested lung fields. Then we did the echocardiogram. It revealed severe biventricular dysfunction with an ejection fraction of 37% with possibility of myocarditis or cardiomyopathy. Following the establishment of this multisystem organ dysfunction, including cardiac involvement, we thought of extensively investigating the baby to identify the possible cause. Then we sent troponin I, D-dimers, fibrinogen, vitamin D levels, LDH, CPK, metabolic panel and everything. Torch screening was sent. Then these reports showed a multi-system involvement from the disease. Troponin was quite high, D-dimers were about 10,000 or 10,700, fibrinogen was high, LDH, CPK all were quite high. Then on 4th day of admission, we did a COVID antibodies on the baby. It came as above more than 10,000. So in this context, we made the diagnosis of multisystem inflammatory disease following COVID infection. Actually, after the admission on the 2nd day, prophylactically, we started IV immunoglobulin 1 gram per kilo, thinking before the diagnosis is made with the background of myocarditis. But baby improved quite a lot with this first dose. LDH, CPK, D-dimers all improved, including the liver function. Then by 4th day, we had this our antibody report. So we confirmed our diagnosis and gave the 2nd dose of IV immunoglobulin as well with the same dose. So baby was improving clinically, and then we start, but repeat echo, ventricular dysfunction was improved but not remarkably. So we thought of giving methyl prednisolone as well. Actually, for steroid use in neonates is not very well established and there is no strong data, but there were case reports with good results. So we go ahead with this methyl prednisolone 10 milligram per kilo per day, and baby showed a good improvement on that. We have been given a regular FFP transfusion to correct bleeding diathesis and vitamin K, enoxaparin and low dose aspirin to prevent blood clotting. So that was the management, and now baby is quite stable on low settings on the ventilator. Once we extubated, but we had to re-intubate because of the pulmonary hemorrhage. Baby's INR was still bit on the higher side. So we are planning to extubate soon once this bleeding problem sorted. So basically this is all about a neonatal management of a baby born to a COVID positive mother. So what you need to keep in mind is there's only a small risk for the baby, and baby shouldn't be neglected. Though it is born to a COVID positive mother, it's our responsibility to look after the baby with optimum care. So baby should receive all the standards of care pertaining to baby's clinical condition. Thank you. I'll be happy to answer any questions at the end of this session. Thanks.
Thank you very much for that lecture, Shama. Thank you very much. We have got a lot of questions from our audience. I will direct them to our speakers. First, can I ask Dr. Jayaman a few questions, Professor Jayaman? I think one of the listeners have requested, what do you think about early versus late ventilation? Now, this has been discussed in Dr. Boteji's lecture also, but we know there's no clear answer to that. Can you elaborate on that?
No, actually the meta-analysis that has been published shows that there is no benefit from early ventilation. That means bypassing the steps, like we go from face mask to venturi to the high flow oxygen and then to the CPAP. The early ventilation has not shown any benefit, and the wait to see policy is still the policy. When it comes to most of the patients, it may be the clinical experience may be different. Now, as Dr. Boteji pointed out, the indications to go to the next step is not only the saturation but the work of breathing. So if you go by, if the saturation is okay and the work of breathing is okay, there is no added advantage of going for ventilation early. Yes. There's a meta-analysis published to this effect, and it clearly says that the evidence is that at the moment.
Okay, there's another question, sir. Can we identify people who are at increased risk of pulmonary embolism?
Yeah, that's same as for the general risk for pulmonary embolism, like people who have certain comorbidities, thrombophilia, that risk is more. But if you want to identify a patient who is going into pulmonary embolism, there are two factors. One is sudden increase of oxygen demand, judged by the SpO2 to FiO2 ratio. And if there is sudden rise of oxygen demand, then you have to suspect pulmonary embolism. And the other fact is that sudden rise of D dimer, like you have D dimer of 500, and suddenly you see a D dimer of 1500, like a very high rise of D dimer, and that is an indication to suspect pulmonary embolism.
Okay, one last question. There are a lot of questions about markers of cytokine storm. And there are a few questions about when to perform and what are the cutoff limits you use in pregnancy with regard to ferritin, LDH levels and
Yeah, the values are the same. I think there's no difference. Values are the same for, as for the other patients. There's no special studies on this, whether it differs in pregnancy. But there are studies done to look at the immune pathogenesis of COVID in pregnancy. And they have shown very minor differences, but still the cytochrome timing and the cutoff values are the same.
Thank you, Professor Jayamana. There are a few questions from Dr. Botheju also. When will you advise to terminate the pregnancy for maternal safety?
Actually, it has to be.
Yes, it's a multidisciplinary thing.
Yeah, probably that's his expertise. So now, if the patient is, is going to be intubated and ventilated, and if we know that the condition is critical, if the baby is viable, and if it is, if the VOG says that he can go ahead with taking the baby out, so we will have a multidisciplinary meeting, and we will decide by the meeting with the VOG's opinion. Yeah.
Okay. One question. Is a vitamin C recommended or high doses of vitamin C?
Now vitamin C, there is no convincing evidence that vitamin C reduces mortality, morbidity, or hospital stay. But in our Ministry of Health guidelines under the nutrition for COVID-19 early on, they have recommended giving vitamin C, vitamin D, and zinc and thiamine for nutritionally deficient people, so patients. But if you don't have, if the treating conditions thinks that the patient is, nutritionally deficient and better add, you can add. But otherwise, there's no evidence as such that it will help COVID-19. There's no convincing evidence.
There's one more question for you. The place of low molecular weight heparin in women with milder disease. Actually, it's coming from specifically asking about a patient with mild symptoms who have been looked after at ICCs with pregnancies around 24 weeks. Do we still have to consider low molecular weight heparin?
Yeah, that of course, actually we have to assess the risk for the pulmonary embolism on DVT for the mother, and if the risk is high, prophylaxis dose is indicated for mild disease. If the patient is less than 24 weeks, risk is less. Okay. So we will not start for mild disease for those patients. But for mild disease, if the patient is in 36 weeks, more than 28 weeks, better we start even for mild disease. Definitely for moderate and severe disease, you have to start. For severe disease, you have to go intermediate dose. And for mild disease, you have to assess the individually and then decide.
Thank you, Dr. Botheju. And few questions to Dr. Harendra. These are of course very difficult ones to answer. One of the few questions that we have is in every day is a woman being looked after in a tertiary care with pregnancies after cesarean section, and then suppose we want to send him to a ICC at a lower level. How can we find a bed? Is your system helps us with regard to that?
Yeah, actually, it's like this now. If a mother is being cared at a tertiary level, and if the clinicians are happy to send the patient clinically, if the patient is okay to be sent home or to be sent for the step down care. Yes, in regional level, we have identified institutions for step down care. So these institutions are available, but we have to understand with the rising caseload, there may be instances where it's not as easy to get the bed. But we have identified in most districts more than one institution where for step down care. So it is available and it can be done. We have to discuss with the regional team and arrange the care. So with the help of the MOMCH and the regional epidemiologist, you can discuss and go for step down care.
Any specific person that we can contact and who is helping or who is coordinating this? That
Yeah, actually, regional level, the MOMCH, the Medical Office of Maternal and Child Health, will be able to support because they have the places. They themselves, regionally have been. They have identified the places, so they will be able to support.
same thing. I think the same issue for the other end also, how to look for a neonatal care facility for a preterm baby with a COVID. Like for example, 31 week, if you want to deliver for a COVID positive mom, if our unit is full, will there be any help from your system to say, okay, look for this place?
Yes, definitely. If the need is there, you can always contact the regional people, and then if the child needs special care, you can always contact even the Family Health Bureau, the Director of Family Health, Maternal and Child Health. Also can help, and in the ministry there's a unit who will help you to identify places where the beds are available, the ventilators are available, and the facilities are available. But then again, as I said earlier, we have to appreciate the fact that the caseload is high, so it may take a bit more time than usual to identify a place. But yes, there is a provision to identify places like that.
Thank you, Dr. Harendra. Two questions to Shyama also. I think one you have already answered. What evidence do you have, madam, to say about transplacental transmission of COVID?
So, our baby is a good example. I think this baby didn't have positive PCR, only the antibodies were positive. So, it is a transplacental transmission, and even there are case histories around the world. They have found babies born to mothers with COVID with positive infection.
Another question, how would you advise a postpartum mother with COVID-19 regarding breastfeeding?
Yeah, breastfeeding is always should be encouraged because there is no transmission of virus through the breast milk. Always baby should be kept with the mother, and breastfeeding should be encouraged because it has its own benefits, as I said earlier, immunological, nutritional and developmental benefits. And if at all breast milk carries antibodies against coronavirus, then it can be beneficial rather than harmful for the baby.
Third question to you, Shyama. Suppose there's a family who's been found to have a positive patients with corona, and there's a neonate or a newborn. Do we need to take that child when the others are being tested? Would you advise the child being tested for COVID?
Ideally, the guidelines says you need to check the baby because otherwise we don't know asymptomatic COVID infection is there in the baby or not. Okay. And the transmission from that baby to others is also a risk. So we need to do the testing and diagnose the baby.
Okay, thank you, Shyama, thank you. Thank you very much, everybody. That brings to the end of our session. Dr. Dilusha Tukol is our secretary. He is going to give a closing remarks and summarize the session.
Yes, so we have come to the end of this important web symposium, Management of COVID-19 in Pregnancy and Neonates. So before winding up, I would like to highlight a few important points from the 4 speakers. From Professor Jayamana's lecture, I think Sir highlighted the important points of pathophysiology, and pathophysiology was nicely explained. And one important message he said was a single negative PCR doesn't exclude the disease. So you need to think about redoing the test if the clinical history is suggestive. And also he also pointed out that in pregnant women, even if the saturation of oxygen is normal, if the work of breathing or if the respiratory rate is high, it indicates that this mother needs urgent attention. So those were the 2 important points from Professor Jayamana's lecture. And Dr. Indika Boteju's lecture, I think again he suggested that in pregnant women we have a low threshold for oxygen therapy, and the ideal oxygen saturation of a pregnant woman should be kept above 96%, and that has to be kept as the cutoff to prevent fetal hypoxia and the mother also going into complications. And he also suggested low dose aspirin for at-risk mothers, even if these mothers are asymptomatic. For all COVID-19 positive mothers, low dose aspirin is indicated. And there were a few interesting points from Dr. Indika Boteju's lecture regarding pre-oxygenation before exertion for pregnant women, because even with mild exertion they can go into a hypoxia. So even minor exertions you need to pre-oxygenate them, especially if they are on a marginal saturation level. And also this important or the novel point of prevention of self-induced lung injury. I think we all learned a lot from that, and that has not been highlighted in the previous symposiums. So this is an indication where you need to identify who the mothers who are at risk of self-induced lung injury and then manage them accordingly. So from Dr. Harendra's lecture, I think he highlighted some very important aspects of the healthcare services available in Sri Lanka for management of COVID-19 positive pregnant mothers and newborns. And we really appreciate all the support given by the Family Health Bureau and all the healthcare staff involved in the grassroots level in this pandemic situation. And Dr. Sharma pointed out that there's no transmission of the virus through breast milk, and that is why breast milk is encouraged even if the mother is COVID positive. And the advantages of breastfeeding are far more than the actual risk of transmission to the baby. But having said that, the mother needs to adhere to all the infection preventive methods when breastfeeding the baby. And also Dr. Sharma highlighted a very important case report that she has managed in her NICU, and this showed us the importance of thinking about COVID-19 multisystem inflammatory syndrome even in newborns with this current pandemic situation. So with these take-home messages, on behalf of the Perinatal Society of Sri Lanka, I would like to extend my gratitude to the 4 speakers. Professor Shaluka Jayamana, Consultant Physician, Colombo North Teaching Hospital. Thank you very much, sir. Dr. Indika Boteju, Consultant Physician from Castle Street Hospital for Women. Dr. Harendra Dasanayaka, Consultant Community Physician from the Family Health Bureau. And Dr. Shama Basnayaka, Consultant Neonatologist at Lade Vijay Hospital. So I thank all of you for sharing your valuable experiences and thoughts on management of COVID-19 in pregnancy and newborn. I'm sure the healthcare professionals who have joined today would have gained a sound knowledge on COVID-19 in pregnancy and newborn, and that you will try to apply this when managing COVID-19 positive pregnant mothers and newborns in your day-to-day life. And my gratitude also goes to Mr. Nuwan and his team, Mr. Nuwan Samir and his team from P&G Healthcare Company for sponsoring this web symposium and all the hard work behind this. And Professor Rasika Herath, our chairman of the CME committee of the Perinatal Society of Sri Lanka. Amidst his busy schedule, he's actually a very busy person and difficult to get a call sometimes even. But amidst his busy schedule, he has been managing to organize these kind of very important web symposium over the last few months on behalf of the Perinatal Society of Sri Lanka. So, Professor Rasika, thank you very much. And last but not least, all the participants, I think we have more than 300 participants who have joined today. And thank you very much for engaging with us on a Sunday, and hope you gain a sound knowledge, and hope that you will try to improve the care for the pregnant mothers and newborns who are COVID positive. Thank you very much and have a good evening.